Okay, thanks everyone for joining. I will get us started here. So it's my pleasure to welcome you all to this week's session of the Infectious Disease Epi Seminar for this spring, and to introduce Professor Greg Gonsalves from the Yale Department of Epidemiology of Microbial Diseases. So Dr. Gonsalves is an expert in policy modeling on infectious disease and substance use, as well as the intersection of public policy and health equity. His research focuses on the use of quantitative models for improving response to epidemic diseases. For more than 30 years, he has worked on HIV, AIDS, and other global health issues with several organizations, including the AIDS Coalition to Unleash Power, the Treatment Action Group, the Gay Men's Health Crisis, and the AIDS and Rights Alliance for Southern Africa. He is a 2011 graduate of Yale College and received his PhD from the Yale Graduate School of Arts and Sciences and the School of Public Health in 2017. He is currently the public health correspondent for the nation, and he is a 2018 MacArthur Fellow. So please join me in welcoming Dr. Gonsalves.
Hi, everybody. I'm glad to be here, even though I'm sitting in Camp Wade Library. The lives of graduate students are precarious enough that I didn't want to break the picket line and walk through them to be with you in person. So you can always come over to the library and say hello. So I'm going to talk today about something that is not my usual NIH-funded research because I had a choice. I could talk about what I usually do, 9 to 5, or talk about the broader perspective about the work I've been doing over the past 10 or so years, and I decided to go with that. And so I'm going to share my slides. Hopefully it'll work. And I think I can get it to work. So I'm going to talk to you today about, oops,
It just went away for us.
I'm going to put it back. Do you
Great.
see it?
Yep.
Great. So I'm going to talk to you about policy modeling in perilous times. And I just need to give a little bit of background for why I'm pitching this talk in the way I am. And I don't think anybody's going to have problems with understanding the context we live in now. And this is a essay by Gretchen Goldman, who's an environmental scientist who happens to be the CEO of the Union of Concerned Scientists, and talks about violence and gaslighting, what authoritarianism looks like, and why we must resist. But there's an interesting piece down in the last paragraph of her posting, which says, throughout history, scientists have played a pivotal role in standing resolute against authoritarian regimes, in being the keepers of observational data and empirical evidence. So my question to us sitting here at the Harvard School of Public Health is, what is our responsibility as keepers of observational data and empirical evidence? Gretchen Goldman makes it not just a scientific duty, but a civic and moral duty as well. So I want to pull us back to think about this in the context of bearing witness. And, two books I read in my old life as a comparative literature major were these diaries by Victor Klemperer from 1933 to 1945. And he writes through the years of the rise of the Nazi Party in Germany and through the war, and says something in his book that stuck out to me. He says it's not the big things that are important, but the everyday life and tyranny which may be forgotten. 1,000 mosquito bites are worse than the blow on the head. I observe, I note the mosquito bites. So I want to talk about policy modeling as observing mosquito bites and describing the small changes in public policy that shape our lives. So many of you in the room know what policy modeling is, but just in terms of a quick introduction, it's the disciplined use of mathematical and analytical tools to structure policy problems, quantify trade-offs, and guide better decisions under uncertainty. It exists to answer a question about what should we do, not what equations can I solve. And usually, or preferentially, we think about simple models that clarify a trade-off, and those being more valuable in a complex simulation that nobody understands. Complexity is useful, but only as much as it gets your point across and helps your audience understand what you're trying to communicate. It's a little bit promiscuous in terms of its tools. It could be from operations research, where I was largely trained, applied probability, optimization, epidemiology, and economics. Um, you know, Policy modeling can be both prospective or retrospective. It could be what could we do, or what should we have done. And I think we're going to most of this talk is going to talk about the latter. What should we have done in a couple of circumstances? And what I would ask you to think about it, what kind of questions would you ask in the context of policy modeling in the current moment, and how might you answer them? My mentor, Ed Kaplan at the School of Management at Yale, always talks about the problem comes first and the methods come later. So think about that in terms of the way you approach a question of public policy that might implicate the fate of many people in the communities we live in. So I want to talk about some examples of policy modeling, and then talk about a larger example which intersects with communicable disease dynamics, because that's where we're sitting and talking among each other today. So a couple of papers we've done over the years have been in this vein of policy modeling, in terms of using simple models to communicate the policy choices that face decision makers across a range of different issues. This is a piece on reducing sexual violence by increasing the supply of toilets in Khayelitsha, right? And it's a very simple model that involves nothing more complex than addition, subtraction, multiplication, and okay, there's one derivative in here, but basically we developed a mathematical model that linked sexual assault to the number of sanitation facilities and the time a woman must spend walking to the toilet. And we're able to build a composite social cost function comprising both the burden of sexual assault and the cost of installing and maintaining public chemical toilets. And we could figure out an optimal or cost minimizing social investment in toilet facilities. And the qualitative understanding from this is that under any version of the model, in a probabilistic sensitivity analysis, it made more sense to increase the number of toilets in the township of Khayelitsha outside of Cape Town than reside in the status quo with the same number of investments in sanitation facilities in that township. This is another piece that I did with David Paltiel and some friends here in Boston at the Mass General Hospital in the CPAC team, about a case called Braidwood versus Becerra, in which a gentleman in Texas was making the case that the HIV PrEP shouldn't be required of employers and their insurance plans because it promoted homosexuality. It was against his religious beliefs. David and I and others said, no matter what you think of the sort of moral statement that this case sort of envisions and brings up, what does it mean in terms of new HIV infections? And we're able to write on a napkin a simple formula for what constitutes the incremental transmission risk arising from the ruling, right? It's the number of PrEP eligible MSM, it's untreated HIV incidence, it's PrEP effectiveness, and coverage levels. The point here is that you could write your formula on a napkin, and a cocktail napkin, and come up with a qualitative understanding that the consequences of this ruling would mean hundreds of new infections across the United States as PrEP coverage decreased based on the ruling, should it have taken effect. And one last example before we move on to the sort of main course is about a drug law in Colorado, in which they're removing possession charges for having fentanyl from having 4 grams of fentanyl, which was considered a felony, and moving down to 1 gram of fentanyl, which would constitute a felony. The idea here is that the new law was much more punitive than the existing law. And what we did is simulate a cohort of people with fentanyl possession moving to the criminal justice system, and then exploring the probability of overdose and incarceration under different scenarios, right? Again, the more punitive drug law that came into place in 2022 in Colorado would exacerbate both incarceration and overdose in the state. Again, a simple Markov simulation model that we used for this paper in the International Journal of Drug Policy. Now I want to talk about a larger piece of work that sort of actually kicked me off on doing what I do for my day job, which is thinking about substance use and HIV, which is about HIV in the context of substance use, and want to talk about Scott County, Indiana, as a case study in public health decision making. Now, I want to give you a little bit of a framing for why this is interesting still in the current moment. In 2020, if you can remember back that far to the beginning of the COVID pandemic, President Trump in his first term named Mike Pence as the head of the COVID response. In fact, in the New York Times, he's in the Washington Post, he said, I think he's done a phenomenal job on healthcare, one of the best, if not the best in the country. Um, Forrest Crawford and I, who did this work on the Scott County outbreak in 2014, 2015, were curious about this choice and what really happened in Indiana. Um, were President Trump's words really indicating that a phenomenal job had been done on the ground? Maybe not. And so Forrest and I have written a paper, and I want to talk you through it as an example of the policy modeling that I've been talking about. So why talk about the outbreak in Scott County all these years later? One is because it involves major political figures, some of them whom are still around, criminalized and vulnerable risk population of people who use drugs, stigmatized health outcome, both that of HIV and substance use, political opposition to proven interventions. If you work in substance use, you know that well-trodden interventions like syringe exchange are still a political football in jurisdiction after jurisdiction across the U.S. It was an interesting case in which the CDC responded along with the local health department. But what was interesting to us is that there were competing narratives about what happened and what public health decision makers should have done. So a little bit more context. The outbreak in Scott County was a slow-growing catastrophe for people who inject drugs. We knew before the outbreak that something was going on because there were a rise in drug poisonings or overdoses from 1999 onwards. There's high painkiller prescriptions and underage prescription drug use, again, in years preceding the outbreak in Scott County. We'd already seen an emergence of hepatitis C among young people who inject drugs, right? I think the first signs of that outbreak are in 2011, in which the state health department knows, the public health community in the state knows, but something is going on in terms of blood-borne infections way before we see a case of HIV emerge in Scott County, right? There's very large gaps in opioid agonist therapy. The need for methadone and buprenorphine simply was not being addressed in the context of the state of Indiana, which is the case nationally. But what's more interesting is that a new version of OxyContin emerges during this time in which this reformulation to a long-acting opioid spurs the switch to injection. So instead of taking the pill, you're now grinding it up, dissolving it in water, and injecting it, which really was the key feature of the pharmaceutical landscape that changed in this moment that really leads to the explosion of HIV infection in the context of Scott County, Indiana. Okay, let's talk about the outbreak itself, right? It was all over the MMWR. The first cases were diagnosed in November 2014. Here's the curve of the diagnosed cases. The initial diagnosis is in November 2014. You have a cluster identified in January. Federal support is called for early in the next year of 2015, but public health emergency, the local HIV clinic, the syringe exchange started all happened later in the spring, right? November 2014, the first case is diagnosed. The state of Indiana investigation begins. There's 17 initial cases by the end of that year. And by March 23rd, we have a team of CDC investigators on the ground. Okay, so this, again, is a slow-growing catastrophe and a growing outbreak. Again, this garnered national attention. In August of 2016, they're talking about how Mike Pence decided what to do about the HIV outbreak. And it's an interesting story in which one of the local sheriffs comes to reaches out to him and says, we need to do something about this. The idea is that potentially a needle exchange would be useful in the context of that outbreak in Scott County. What happens is that there's a long, drawn-out deliberative response by the governor in which he preys on the issue and then finally makes a decision, right? So again, first infections November 2014. The HIV testing clinic doesn't open until 3 months later. We get a public health emergency in the end of March 2015. April 4th, again, we're moving 4 or 5 months after the outbreak starts. We get the authorization of a temporary needle exchange. But then on May 5th of that year, Governor Pence signed a bill allowing counties to establish syringe exchange programs for an HIV outbreak, but also signs a bill upgrading possession of syringes to a felony charge. So what he gives with one hand, he takes away with the other. Okay, so we're faced in the wake of the Sussex County outbreak with these counterfactual claims. Els Campbell, who's was in the laboratory branch at CDC, writes in those years that had a syringe exchange program been in place prior to the outbreak, the explosive phase would have been blunted. Josiah Rich and his colleagues at Brown talked about what happened in Indiana as being predictable and avoidable. And NIDA director Nora Volkow, who runs the institute, said, pretty bluntly that this epidemic shouldn't have happened. We've known for many years that providing free needles to injecting drug users is a strategy that can prevent the spread of HIV in a community, right? It was far too late to prevent the outbreak, the needle exchange that they put into place in early April 2015. So, this was not a quiet debate. It shows up in the New England Journal, in which Jerome Adams, who is the health commissioner in the state of Indiana, who becomes our Surgeon General several years later, argues that he spent time arguing and trying to convince other officials to authorize syringe exchange programs, and that many of the sort of commentators were ignoring the political reality of rural settings, right? They called us armchair epidemiologists. Any of the criticisms from people like Josiah Rich or Stephanie Strathy, a well-known HIV substance use researcher at UCSD, they went head to head in the New England Journal in dueling commentaries over those years following the outbreak in southern Indiana. So now we're left with the question of political epidemiology and epistemology, right? Did Governor Pence's syringe exchange program authorization stop the outbreak? The question for us is, would an early action by Pence and Adams have reduced the toll of the HIV outbreak to begin with? So Forrest and I, as we sat down to think about this, we wanted to answer these questions in a credible, quantitative way. We didn't want to sort of make a moral or a persuasive argument. We wanted to make this in a way that could be credible scientifically, but also do as much as we could without using model or statistics, right? We wanted to make this incredibly transparent about what we were trying to show here and the way in which we showed it. And we needed data, right? We needed data to make a credible argument to people who disagreed with us too. Is there any evidence that convinced political adversaries of the need for public health interventions that they morally oppose? The question is an open one. It's not quite sure what indeed happened in the end in Scott County, but that's where we started our discussion. So we needed some data. As you saw, we had the diagnosis curve from the MMWR and the New England Journal paper that came out on the outbreak, but we needed something else. We need to have an incidence curve. And one of the interesting things is that infection recency assays were done in the context of this outbreak, and they don't get really done subsequently in other HIV outbreaks among people who use drugs, at least that I know of, because we've asked for it. But this data was there. It was reported in several publications by the Indiana State Department of Health and the CDC investigators, right? And so we asked for the data from CDC, from Indiana, and they said no. Went to our friends at the law school and said, could you submit some FOIA requests to us, to the CDC in the state of Indiana? And they said no, even though this was all data collected with public money. But if the government won't give you the data, steal it. And so we digitize the information in a public figure. And now before you think of this as theft, Els Campbell and the authors who wrote this paper, in which the blue curve is represented on the left, made the suggestion directly to us. They said, look, the data you need is already right in front of you. Just take the paper, digitize the data, and use it for the analysis that you'd like to put together. And basically, the blue incidence curve in the Campbell paper gave us bounds for the true incidence curve for infections that we can compare it to the known trajectory of HIV diagnoses, right? So we can look at the blue curve is our incidence curve, and the red line there is the infections as they were diagnosed in the end of 2014, beginning of 2015. And that would allow us, once we had this data, we reconstruct undiagnosed HIV infections, right? If you take your cumulative diagnoses from cumulative infections, we had now had the bounds for undiagnosed HIV infections, right? And these here you see the cumulative HIV incidence and the cumulative HIV diagnoses, and then the undiagnosed HIV infection here below. And what you can see is that much of the infections start earlier, way before November 2014, where the first diagnosis is, and where the peak happens in January 2015. But you can see there's a long curve of undiagnosed infections and cumulative HIV incidence that's been simmering in Scott County since at least 2011, right? 2014 was the first time we got our eyes on the outbreak that was happening right before our noses. Okay, so there's a little modeling involved in this analysis. So DVT equals cumulative diagnoses of the observed ones from the MMWR in the New England Journal paper. We said the cumulative HIV incidence we stole or we borrowed or we digitized from the paper by Els Campbell and colleagues, and we have upper bounds and lower bounds for that. And then we can recreate the number of undiagnosed infections, right, by subtracting the two. And then we can create a diagnosis rate, right, here in the equation gamma T, et cetera, right? And then we can craft our incident rate dynamics. And this looks familiar to everybody in this room because it's the bounds for all compartments of a dynamic HIV transition model, which we've reconstructed with available data and very, very few statistics, right? Actually, no statistics. It's all available data. We're just plugging these things into the model. And so, for a very crude model, a first pass, the model itself doesn't look too bad compared to the raw data we had. If you look at the model projections in the lighter colors on the first, the lighter colors in the first panel, you see the undiagnosed HIV, and you see the raw data here. You can see the cumulative HIV incidence in the raw data and the cumulative HIV incidence model projections, and then the cumulative HIV diagnoses and cumulative HIV diagnoses of the model projections. There are wide intervals here, but in general, they follow the same trajectory as the actual data that happened in Scott County during those years. So what we wanted to do was just to think about what would happen with estimated and counterfactual diagnosis rates. So we were able to reconstruct the diagnosis rate before, right? I talked about it a few slides ago, the actual case finding rate that we saw from 2014 to 2012, 2011 to late 2014 was nearly zero. But we wanted to think about what would happen if we took the same case finding rate that happens in the outbreak investigation and moved it backwards to 2013, right? And the reason I raised 2013 is that's the year that all the HIV testing clinics closed in rural Indiana as the state legislature stopped funding to Planned Parenthood, which was the main service provider for infectious disease diagnoses, sexually transmitted infections, HIV in these rural communities. So he said, what if we just simply slide back time and think about our case finding rate in a counterfactual scenario in which it starts in 2013? And what we found is that instead of 235 cases, where the epidemic ended, you had a range of cases just simply with moving the start of diagnoses back a year or so, you're down to 0 to 56 cases. The idea is that earlier diagnosis, earlier surveillance would have blunted the epidemic. We also did it for 2011. Remember, I mentioned that the HCV an outbreak of HCV happened in Indiana, which had gotten the attention of the state health officials. If you move the start of diagnoses back even to 2011, of course, you stop the epidemic in its tracks because the epidemic is really not even taken off until later in that decade. So we put this into a web app, right? Which not quite sure is still functioning after all these years. But the idea too is to provide some transparency to those who would read our paper or those who would hear about our paper. And in the app, you can change any of the parameters you'd like. You can change our smoothers. You can sort of interrogate different scenarios based on the data that we acquired from the digitized journal article, but also from CDC and other publications. The idea is to be transparent and clear about our methods and how we did this model from the get-go for those who would look at it. So what happens to Vice President Pence? Did he do a good job or did he not do a good job? Our question, rather than a qualitative judgment on the vice president, was that the outbreak could have been avoided in part or in whole by simply offering earlier diagnoses and HIV testing in rural communities in southern Indiana. This is not about needle exchange. It's not about methadone or all the other kinds of HIV prevention tools we have in terms of abrogating HIV outbreaks when people use drugs. And we did this paper in Lancet HIV back then, and my colleagues, Chris Beyer, who was at Hopkins and is now at Duke, wrote a piece called No More Scott Counties. And he said, look, there might have been a debate, there may have been sort of dueling commentaries before this paper, but at least in a qualitative sense, the Scott County outbreak could have been avoided if we had done the right thing and applied the science that we know is important and crucial in stopping HIV outbreaks among people who use drugs. So Surgeon General Jerome Adams, right? He rises to become the Surgeon General in the Trump administration. He does not have fond feelings of the time in which he went toe-to-toe with epidemiologists and other public health officials and experts during Indiana. And he said, the researchers, he said, were armchair epidemiologists. And at this point, he's pointing right at us, right? He says, the piece in the Washington Post talks about our study in Lancet HIV, and Jerome says we were armchair epidemiologists, right? And we did do it from our comfort in our office at Yale. We weren't on the ground in Indiana, right? But we showed that an HIV outbreak could have been prevented or mitigated by an earlier response. Incidentally, my colleague Brandon Marshall at Brown University did another more complicated model several years later, in which he uses much more sophisticated tools for modeling the outbreak, but also adds syringe exchange, opioid agonist therapy, and HIV testing into the mix. Shows the same thing. You could have stopped this epidemic in its tracks, this outbreak in its tracks, if we'd gotten involved in an earlier response. So fast forward, right? For those of you who remember this time, this was a live issue. Was the vice president fit to lead our coronavirus response? Forrest and I wrote a piece for Politico magazine back then about how Mike Pence made Indiana's outbreak worse. And for those of you who know me, it's pretty easy for me to go spouting off about what I think. But Forrest, for those of you who know him, probably don't think it's as obvious that he would speak out in the context of a new pandemic and a volatile political situation. But to his credit, he's the one who pushed to take our results from the Scott County outbreak in our 2018 paper and put it into the public domain in 2020, just as the COVID pandemic was swooping over the country. So, it's really easy to criticize Governor Pence about praying about needle exchange before allowing it in Indiana. And it's hard, but probably we should give Jerome Adams a little bit of credit for convincing Governor Pence to respond, and for working them through the trade-offs and the choices they'd have to make. We should give them a little bit of credit, and it's not something we should easily dismiss. But in general, we tried to use data and make an argument that would be convincing to anyone in this project, in this very simple policy model. We wanted to be convincing to anyone, whether you're a statistician or not, whether you support harm reduction or not, whether you support public health or not. So everything ends up with a set of strange bedfellows, because in 2013, Jerome and I write a piece called Orange County Needs Syringe Exchange Programs to Reduce the Harms of Injection Drug Use. And so did our paper change his mind about syringe exchange? It's not quite sure. But Jerome and I are writing in August 2023 in support of the Orange County Needle Exchange Program that was under threat from the county Board of County Commissioners. Jerome and I also, along with other public health experts, begged the Scott County Board of Commissioners not to close the Scott County Needle Exchange, which they did a couple of years ago, even though they knew the risks and they knew the impact of HIV in their community, right? So no more Scott counties. Well, it's not the case, right? It's not the case at all. Since Scott County, we've had outbreaks all over the country, in Seattle and Portland, in Duluth, in Hennepin and Ramsey counties, in Minnesota and Wisconsin, in Miami, in Western North Carolina, in the heart of Appalachia, in several counties in West Virginia, in Philadelphia, and then up here in Lawrence and Lowell, Massachusetts, and Boston, and then an ongoing one in Bangor, Maine, just not very far from where we are sitting right now. And so, where we'd like to talk about having no more Scott counties, there's much more work to do. And I got a chance to talk to Jonathan a little bit this morning about the work that we do in the Public Health Modeling Unit, which thinks about the context of how we prevent, detect, and manage outbreaks of HIV among people who use drugs, because this is an ongoing public health issue in which the sequelae of both substance use and infectious disease come together in a perfect storm. And so there's a lot more work to do in this area, which is sort of my day job and the work that NIH supports me to do. But creating actionable policy evidence for people, whether they're in South Africa and thinking about sanitation and sexual violence, or they're talking about needle exchange in a small rural county in Indiana. The tools we can use are varied, and it's up to us to sort of put it to use to answer questions in the short term when they can be used by the people who need them most. And this is a collaboration with Forrest, but Ellsworth Campbell and Bill Switzer in the laboratory branch are the ones who made it possible, because they provided the recency assay paper, which we could digitize. David Paltiel, Ed Kaplan, and Paul Cleary, Josh Warren, who I work with now, and others. And much of this work is supported by NIDA, a little bit by NIMH. And if you have questions, I'm happy to answer them. Or talk about
Great.
any aspect of my work.
Thank you so much. That was really fantastic, Dr. Gonsalves. Happy to open the floor to questions.
And I'll talk about anything, this or other stuff too.
Someone in the grad lab, go ahead.
It's me. Hi, Greg. It's Jonathan. That was fantastic. Thank you very much for that. There are so many things one could imagine modeling right now with all of the changes in policies going on at the federal government and globally. And I was wondering, everything from the health policy decisions themselves to the impact of closing the Strait of Hormuz on petrol availability, and then where so many countries have to basically decide what they're going to spend money on, whether it's buying petrol or providing health care or so on. And we saw there was an article in the New York Times earlier today that the largest manufacturer of condoms is increasing prices substantially because of the cost of all of both getting access to the supplies that they need and then transportation issues. Amid all of these potential health issues, how do you prioritize which ones are going to be the most important ones to engage in modeling? I mean, we wish we could do it all, but how does one think about potential for impact, and then how do you go about? So that's one question, and then another question is how do you go about engaging as you effectively did with Jerome Adams, such that you're able to work with him and write a piece with him subsequently to to really engage and help inform the discussion around these issues at policy levels?
I mean, so the easiest question is I try to stick to infectious diseases, but I don't. Um, you know, Ginny Pitzer, who I know came up to give a talk um, recently at the CCDD, and we have a new paper coming out about the potential of resurgence for rotavirus, right? In the context of the shifting federal vaccine guidance coming out of HHS. Um, it's an obvious piece of work for people in our unit to do because it's infectious disease modeling. That's the bread and butter of the work we do. Melanie, who's here on the call, is also involved with that. But then Alyssa Belinsky roped me into it, thinking about what the changes in abortion legislation in the United States means for the health of pregnant women in the context of pre-viability and complications of pregnancy during pre-viability. So so you meet them where they come. Try to stick to what you know best. But I missed a call earlier today, which was thinking about the health impact of the ICE raids in Minneapolis over the first course of 2025. We had done a difference in differences analysis on the Muslim ban in Minneapolis 2 or 3 years ago, and showed an effect of that sort of modest local impact that we saw through that analysis. So try to stay close to things that I know about, but when people come to you with questions, whether it's sexual violence in Kailicha or healthcare utilization in Minneapolis or the Muslim ban, etc., do what you can to help. I think Alyssa has a question. Oh, and the Jerome Adams thing. Jerome is a weird case because once he left the Trump administration, he became pretty vociferous and outspoken about the importance of needle exchange, but also COVID mitigation measures, so that he became sort of more hardcore public health than many hardcore public health people I know. Alyssa?
So first of all, thank you for going on journeys with me on issues that I think are important. It is always great to be on a team with you. I want to ask you a question that is a little bit more of a devil's advocate question, but one that I think is really important to think about, and I know I don't have a great answer to. And that has to do with when to model and when we just don't have enough data. So the particular example I'm thinking of is your OFID paper on Braidwood versus Becerra, where the abstract is like this may lead to more than 2,000 new infections, but that really hinges on the fraction of PrEP indicated MSM men who will maintain coverage. And like what you wrote about in the paper is this value is unknowable. There's reason to believe it will be less than the current value of 28%. There's equally good reason to speculate that it will be greater than 0%. While we believe our baseline value of 10% represents a plausible assumption, we urge readers not to latch onto that value. And I asked David, like, how did you pick 10%? And he, was all David and was like, we pulled it out of where in a classic David way. And I guess my question in that case is like, what made you feel comfortable publishing a number of 2000 versus saying, we don't know? And when do you think we should wait for data versus publish something kind of speculative?
So a couple of things. I'll move away from Braidwood and talk about the sexual violence sanitation paper, where we had no reasonable data to parameterize our model, right? Walking speed, the entire model was based on parameters with ranges you could drive a truck through, right? And we did use probabilistic sensitivity analysis to say, look, most of the times, no matter how far you vary these, you're going to get an answer that's going to be tilted towards putting more toilets into Kailicha than not. The other piece of this is, and David probably talked about it in his talk at Brown, he did a study of HIV testing on college campuses, right? Early on in the pandemic, we didn't know a lot of the sort of model parameters for COVID in those years. And it was a really simple model. And it was used by dozens and dozens of college campuses to think about the frequency of testing for COVID-19. Dan Larimore comes up with a much more complicated model 6 months to a year later and says the same qualitative gives you the same qualitative understanding. So like back to Braidwood,
So, okay, go ahead.
back to Braidwood,
Mhm.
the idea is that we're not interested in you latching onto it as a point estimate, but to think of it even in the worst case scenario of what might be your nervousness about the parameters, you're still going to get an increase in HIV infections by what happened in the context of Braidwood.
So here's where I would push you on this. And I'm only pushing you because I love you and I think this is super important for modelers. The first two examples that you gave were cases where I think you say, look, we have uncertain parameters, but the qualitative policy action is very clear. Like have more toilets, test for COVID in a way that privileges high frequency testing. Would argue that in the third case, like you could actually end up with very different qualitative conclusions, at least if you buy your own conclusion, which says it could basically be anything from no change to getting rid of all prep. And so I would argue that is a case where you can't say there is a clear, like, qualitative conclusion. So what was the thing that had to be in case three? Because I agree with you. Case one and two, super clear. Case three, I think, is really tough as a modeler.
I can't argue with you because I will lose. I, yeah, it was the assumptions were weak. Um, you're right. It could have turned out in different ways. I think we didn't overstate our confidence in the parameters in the model. We said this is what we thought. This is what our best guesses were. And at some point, you have to make a call, right? And a decision has to be made in the moment. And we could have waited for better data, but would the better data have gotten us appreciably different questions? We have a grad student working on an extension of this, and the data still is terrible, right? And so were we leading people down sort of a primrose path and making assumptions that didn't support our conclusions? I'm not quite sure. I think we were pretty straightforward about what was going into the model and the uncertainties associated with each of those sort of parameters that we used.
Awesome, thanks. And thanks for letting me give you a hard time as well.
You giving me a hard time, is a good thing.
I also had a question related to how you choose kind of what policies you might look at. And in particular, I think um, in policy and science communication, there are sometimes these kind of retrospective examples like the Scott counties, and then there are prospective examples. And I think right now there are a lot of prospective examples as well of, how all of these policy changes will be impacting any number of health indicators. Um, on the other side of this, once you have kind of the model done and you're looking to kind of convince people, um, have you seen a difference in how retrospective cases that are more tangible may persuade versus something that is prospective that feels more amorphous?
So it's interesting. The retrospective ones are sort of bearing witness, right? It's like this happened, you could have done differently. It's all water under the bridge. The interesting things are when you do policy models in real time, which, a lot of the ones during COVID were, whether they were about sort of, ICU capacity or testing frequencies. When they are responding to sort of desperate programmatic or policy needs, they've been much easier to sort of see them adopted. Um, as a the retrospective cases aren't necessarily game changers in terms of people's policy opinions. I think they sort of add to the weight of history, but where I've seen the models make the most difference is when you're moving them forward. Like when it's happening now, there's an mpox outbreak. There's COVID is happening, like things that have to be, when a decision that needs to be made in the very short term, these policy models, which are easy to stand up, often have a little bit more impact because people are looking for guidance to what to do, even in the context of great uncertainty.
Great, thanks.
Melanie.
Hey, Greg, good to see you. And I apologize, there's a little background music, but you're also a very prolific writer of op-eds. And so I was wondering if you could speak a little bit to that process of sort of shifting the way that you're thinking about a problem from objectively and scientifically to maybe more persuasively. Yeah, thanks.
So you have to be of two minds, literally. One of the it you know my history. Like I spent 20 plus years working for faculty organizations. It's easy to 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 write an op-ed or an essay or commentary. It's very easy. What's harder for me is to keep the dividing line intact. Um, I teach a course called Political Epidemiology, which the last class was on Tuesday, and it's half about causal inference and then applied examples. And the reason I decided to teach that is because I wanted to put students in the case where they needed to hew to very strong assumptions and methods to make a case without potential for bias. I think with policy modeling, it becomes a little more iffy. Um, you're saying this is a qualitative understanding, it's broad based, but like it's very I try to keep a firewall between my personal opinions and what I might think is going to happen in any sort of rigorous analytical study that I might do that I do on a daily basis. It's harder it's hard to keep them both in my head at the same time, but at least I try.
Thanks, Greg.
Yeah, I don't want to do cargo cult science and be like, have the answer before me and then work backwards to get the answer I want.
I will tack on to the questions that were asked. It's a very interesting discussion. Sort of how to communicate the uncertainty, particularly around these policy models, to an audience who are not modelers, and if you have lessons learned from that. As an epidemiologist, I feel like uncertainty is where we focus on for good reasons, but sometimes I think that kind of loses a lot of people when you start explaining all the assumptions going in. So what is the right balance to reflect on the uncertainty, but still sort of narrow down on the key evidence that is rising from your study?
So one is like to be upfront. Like when we present the paper on sanitation and sexual violence, we say like all these parameter values, they're derived from the literature, but they are grossly uncertain. And so to make the case with humility up front that like, look, this is the way we collected the data, this is our level of confidence in it. It was helpful to do the probabilistic sensitivity analysis to say, like, look, no matter how you varied these parameter values, in the vast majority of cases, the model is going to still give you the same answer, right? But also to think about policy models as a first pass, right? A decision has to be made right now, even in the face of uncertainty, which we're going to describe to you. This is our best guess for what the trade-offs are and what might be most reasonable to do. Again, like, another study may come down 6 months later and destroy your conclusions, or it might support it. Most of the times, the subsequent studies are much more elegant and sophisticated, but basically offer the same kind of analysis in terms of the overall understanding for decision makers.
Any other lingering questions in the audience? Okay, with that, if everyone could please join me in thanking Dr. Gonsalves. Thank you so much for coming. We really appreciate your talk, and we look forward to seeing everyone at future seminars.
Bye, you all.
Thanks so
Thanks for
much.